Okay, you should be able to see the screen now.
Yeah, one thing I want to add,
Yes.
like ectopic pregnancy management. If the patient is not hemodynamically stable, you said that go for surgery. If the patient is stable, hemodynamically stable, and beta HCG less than 5,000 and no fetal cardiac activity. 2 point, beta HCG is less than 5,000 and no fetal cardiac activity. If these two criteria fits, then MTX can be given. If the patient does not have any sort of contraindication like um, active liver disease, renal disease, pulmonary disease, patient is on breastfeeding or thrombocytopenia. If beta HCG is not more than 5,000 or presence of fetal activity, then go for surgery. And MTX candidate. For MTX candidate, we can give methotrexate therapy. Got my point? So
Got it.
for methotrexate, there are like beta HCG. There are some criteria that beta HCG should be less than 5,000, no fetal cardiac activity, and the ectopic mass size should be less than 3.5 centimeter. If the mass size is more than 3.5 centimeter, we should not give the methotrexate.
Got
Okay,
it. Mm-hmm.
okay,
Thank you. Okay. 32 men brought to the physician by his wife because he has fallen several times and has had progressive confusion during the past 3 days. He reports difficulty keeping his balance while walking. He sustained left femoral fracture in motor vehicle collision 3 years ago and right metacarpal fracture in a fight 1 year ago. Okay. He has a history of pancreatitis, GERD, and MDD. Current medication, pantoprazole and sertraline. He's oriented to person and place, but not to time. Um, Temperature is fine, pulse is high, BP high. Exam shows diffuse difficulty with conjugate gaze and bilateral weakness on abduction of both eyes. Abduction of both eyes. Okay. His gait is broad based and ataxic. Labs hemoglobin is, if that's normal. MCV is 98. Where is the hemoglobin here?
MCV is normal.
Yeah, hemoglobin, he's a male, so is a bit low. Hematocrit is a bit low too. Serum total bilirubin is, I believe that's normal, and AST and ALT are high. Total bilirubin is normal. Yeah. Supplementation with which of the following will most likely have prevented this patient current condition?
Okay, this is Wernicke encephalopathy, deficiency of vitamin B1. Okay, Wernicke encephalopathy, vitamin B1. Most commonly in patients with alcohol use disorder. Most commonly in patients with alcohol use disorder. Anorexia nervosa malignancy. Anorexia nervosa malignancy, hyperemesis of pregnancy, among other conditions. It presents classically with encephalopathy, ataxia, and oculomotor dysfunction, nystagmus. So there is ataxia, encephalopathy, and oculomotor dysfunction, that is nystagmus. This patient's presentation is consistent with alcohol use disorder, where it is said that he is alcohol use disorder.
No, it didn't. They didn't say anything about alcohol.
Okay,
Oh, I mean, maybe the pancreatitis is a clue, but they
okay.
didn't say anything about.
Alcohol, yes, alcohol can cause pancreatitis.
Oh,
Okay,
and maybe all his accidents that he's been having. He had a fight, like a bar fight, and he had a motor vehicle accident. I guess they're giving you clues without really telling you he's alcoholic.
Okay.
Yeah.
Pancreatitis is an important clue.
Yeah.
Okay. This patient's presentation is most consistent in alcohol use disorder. The resultant consequences include aggressive behavior, pancreatitis, nutritional deficiencies. Over time, thiamine deficiency can result in damage and atrophy of the mammillary body, visible on MRI, mammillary body visible on MRI of the brain, which manifests Wernicke encephalopathy. This typical clinical presentation of Wernicke encephalopathy is a triad of acute mental status, ophthalmoplegia, nystagmus, and ataxia. Acute mental status, ophthalmoplegia, and ataxia, the symptoms of Wernicke encephalopathy, are reversible but increase the risk of developing Wernicke-Korsakoff syndrome, also known as Korsakoff psychosis, in patients with chronic alcohol use disorder if not immediately treated with high-dose IV thiamine therapy. Wernicke-Korsakoff syndrome is characterized by irreversible condition that features anterogate or retrograde amnesia, anterogate or retrograde amnesia, along with the consequent tendency to confabulate or verbalize false stories or memories in order to compensate for the inability to remember. Prevention of the progression of Wernicke encephalopathy includes thiamine supplementation, whereas the treatment consists of intravenous thiamine administration. If left untreated, it can lead to coma and death. These patients' alcohol use should specially be addressed as well as to prevent further episodes and worsening. This is best addressed once the patient is no longer altered on a long-term basis with a multidisciplinary approach led by the primary care physician. Okay.
Okay. Next. 11-year-old boy brought to the office by his parents because he has refused to attend school during the past 2 months. His parents said he has become increasingly anxious during this time. He has refused to give them an explanation for why he's avoiding school. The patient received 4 months of psychotherapy at the age of 8 years old because of insisting on changing his shirt several times before leaving the house to go to school. Was always late. According to the parents, he was diagnosed with anxiety disorder and his shirt changing behavior stopped after 10 sessions. He has no history of serious illness or recent medication. Physical exam is fine. When interviewed alone, the patient explains to the physician that my mother has developed diabetes. I cannot get it out of my head that she will die if I go to school. He adds that several times daily he checks to make sure there is enough insulin in the house. Which of the following is the most likely diagnosis?
So it's OCD.
Mhm.
We don't need the explanation because chart changing behavior and another clue like he checks insulin, enough insulin in the house or plenty of times, so looks like OCD.
Okay. Mm.
Next.
19-year-old woman brought to the office because of a 3-month history of recurrent palpitation and lightheadedness. Wow. She is a college athlete, and the episode usually occur during vigorous exercise, lasts 2 to 3 minutes, and subsides spontaneously. She has been in good health and does not take dietary supplements or medication. CBC and C serum electrolytes and TSH concentration are normal. ECG is shown. Which of the following is the most appropriate next step in management?
Okay. If you find in the ECG there is short PR interval, normal PR interval is 3 to 5 small square. Like what is PR interval? PR interval is onset of P wave to onset of QRS the end of the QRS complex.
Mm-hmm. What do you see? Which one are you looking at? I
And
need
there is
to.
in the slurred upstroke. Sort of keyword once the beginning of the QRS. Sorry, beginning of the QRS. Okay, I'm explaining this to you because this ECG is important. This WPW syndrome is very common.
Mm-hmm. Right here, right? So,
Yes, there is
mm-hmm.
slurred upstroke. Okay,
Mm-hmm.
so you found it. So short PR interval and slurred upstroke of these QRS complex looks like WPW syndrome.
Okay.
Okay. Mm, so this patient with recurrent palpitation, exertional lightheadedness, recurrent palpitation. This patient with recurrent palpitation, exertional lightheadedness, and ECG shows PR interval. ECG shows PR interval, shortened PR interval, and has a consistent with WPW syndrome. WPW syndrome in a structurally normal heart. The electrical conduction originate the electrical conduction originate in the SA node is conducted through the AV node and down to the Purkinje fiber. The pathway of conduction leads to coordinated contraction of the atria to ventricle. In patients with WPW syndrome, in patients with WPW syndrome, there is an accessory electrical pathway, the bundle of the Kent, that directly connects the atria and the ventricle, allowing for conduction to bypass the AV node and for early contraction of the ventricle to occur pre-excitation. The pre-excitation leads to shortened PR interval and the slurred upstroke of the QRS complex delta wave. Patients with WPW syndrome on their ECG are predisposed to several arrhythmia include atrial fibrillation, atrial flutter, AV re-entered tachycardia. Patient who develop one of the arrhythmia may present with palpitation, shortness of breath, lightheadedness, syncope, chest pain, or sudden cardiac death. If a WPW syndrome is suspected, electrophysiology studies can be conducted to confirm electrophysiology study can be conducted to confirm the presence of an accessory pathway. For patients with WPW who are in acute arrhythmia, AV nodal blockers such as adenosine, calcium channel blocker, beta blocker should be avoided. So in WP, adenosine, beta blocker, calcium channel blocker should be avoided as they will block any conduction through the AV nodes, resulting in all conduction going through the accessory pathway, which can lead to ventricular arrhythmia and death. Instead, procainamide is recommended for termination of this type of arrhythmia, and cardiac and catheter ablation should be performed. Okay, it's
How
very
did you check? How did you check that the PR was low? Was short here? Which one did you look? Right
okay.
here,
PR,
it was short.
okay. Just where is the P wave? Look at the lead V3, V3 lead. This one,
Mm-hmm.
yes. So this one is start point, onset of P wave to
Mm-hmm.
onset
Okay.
of QRS complex. Only two small square.
Onset of QRS wait, I thought P wave is here. Onset of QRS complex will be here.
Yes. So
So
it
it's
is it is shorter. It is short PR interval. Normal PR interval is 3 to 5 small square.
3 to 5. Oh, okay.
And look, there is a slight upstroke. Like
Yeah,
it
I see.
is, yes. So shorten PR interval, the beginning of the P wave and the beginning of the QRS interval. Got it?
Okay. 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 Okay.
So if you find WPW syndrome is a very uh, classic topic for USMLE,
Okay.
and what we should not give, that is another question. Like we should not give adenosine, we should not give beta blocker and calcium channel blocker, and we can give the procainamide like antiarrhythmic drug.
Okay.
Okay.
All right. What is cardiac electrophysiology? What is it? Is it like what is it?
uh, Cardiac electrophysiology, I think that it looks at the function of the heart. Like go to the yes, you can search because I'm not very clear with this concept. So electrical cardiac activity.
Hmm. Okay. Like I guess they put something in your heart to measure electrical activity. Okay. Okay.
Okay.
Yeah. Next. 57 woman gravida 2 para 2 comes to the physician 3 weeks after noticing a mass in her right breast during exam. 10 years ago, she underwent stereotactic biopsy of the left breast that showed a benign adenoma. Okay. Menarche was at 13. Menses occur at regular 28-day interval until menopause started like 6 years ago. She delivered her first child at 28, and the patient maternal aunt had breast cancer diagnosed at 67. Examination of the patient right breast shows a 3 centimeter fixed tender solid mass in the upper outer quadrant. The regional, no regional lymphadenopathy is palpated. Exam of the left breast shows a faint surgical scar but no abnormalities. Which of the following is the strongest predisposing factor for breast cancer in this patient?
Okay. Current age is the okay. Breast cancer is the most common non-dermatologic malignancy in which assigned female at birth and commonly presents as breast mass, mm, a nipple retraction, axillary lymphadenopathy. However, it may be asymptomatic, diagnosed on screening mammography. Risk factor for the breast cancer development include advanced age or postmenopausal status, exogenous estrogen administration, and a family history of premenopausal breast cancer, genetic mutation, BRCA1, 2, and early menarche, late menopause, nulliparity, and obesity. Advanced age is the most common risk factor for the development of the breast cancer, with the incidence of breast cancer increasing greatly with age. This patient postmenopausal, which makes her current age her strongest predisposing risk factor for breast cancer. Additionally, appropriately timed menarche, menopause, childbirth has has no significant personal or family history of breast cancer. Evaluation of palpable breast mass first involve mammography depending on the age of this patient and a core needle biopsy of the lesions that are concerning for breast cancer. Okay, so current age, very uncommon word.
Current age. Okay.
So postmenopausal maybe the as he is postmenopausal.
Mhm.
So late menopause or postmenopausal may be the cause. Okay.
Okay, so early menarche and late
Late menopause, nulliparity.
okay. Okay. Next,
Yes.
9-year-old girl brought to the physician by her mom because of concern that her daughter's breasts have been enlarging during the past 3 months. The girl is dressed similarly to her mother and says that she enjoys wearing her mother's clothing, playing with makeup, and being a girl. The mother's only medication is progestin OCPs. The patient is at the 80 percentile for height and weight. Breast development is sexual maturity stage 2, and pubic hair development is stage 3. There is scant axillary hair. Exam shows no other findings. Which of the following is the cause of this patient breast development?
Okay. Puberty refers to normal hormonal or physiologic changes that occur in this age. The most common range for the onset of puberty is for female is 9 to 12, although this can vary based on the factor body weight, genetics, ethnicity. Precocious puberty refers to the onset of secondary sexual characteristics before 8 years. So precocious puberty is development of secondary sexual characteristics before 8 in female and or 9 before 9 in male. It can be idiopathic or caused by caused by a variety of conditions such as central nervous system lesion, ovarian or germ cell tumor, adrenal disorders, genetic defects such as McCune-Albright syndrome. Normal pubertal development in female often starts with breast development, followed by breast development, followed by pubic hair development. The patient is progressing through the normal pubertal milestone at an appropriate age. No further workup is necessary. Reassurance is to be done. Okay.
Boobs, pubes. Okay. The mnemonics is like boobs, pubes, and I forgot the last one. But first is boobs, which is breast, then
Breast,
pubes, which
pubes,
is
pube.
hair,
Yes.
and then I don't remember.
Menses.
Oh, boobs, pubes, and menses.
Yes.
Doesn't rhyme. It doesn't rhyme. The last one. Okay. I feel like it's another one. That one doesn't rhyme with the boobs, pubes. Okay. Okay. Got it. 4-year-old boy brought to the ED by his parents because of a 2-day history of increasing severe pain in his right leg with associated limp. He has not fallen or sustained any trauma. 1 week ago, he was treated with amoxicillin for middle ear infection. He has no history of serious illness and currently takes no medication. He's at the 50 percentile for height and weight, vital signs normal. Patient holds the right hip
Right
flexed
hip
and
flexed.
externally rotated. Is 4 years. Passive range of motion of the right hip is limited by pain. On X-ray of the right hip shows no abnormalities and leukocyte count is, I guess, normal. Erythrocytes in the ESR is C-reactive protein is normal, so I'm guessing ESR is normal too. Which of the following is the most appropriate treatment? Let me see, ESR. I think there is a term for ESR here.
This
Uh,
patient, like,
uh,
what is your diagnosis?
he had a
Like
uh,
age 3 to 8 or 2 to 8 with like hip pain and there is problem in, sorry.
like the transient synovitis because
Yes,
he recently had an infection.
yes. Recently have an infection, so it's transient synovitis, so ANSAID is the drug of choice. That's it, and it is self-resolving. Though, oh yes,
Right?
yes. Next,
9-month boy brought to the office by his parents because they are concerned about swelling in his abdomen that has been present since birth and has increased during the past 2 weeks. The patient diet consists of cow milk based formula, baby food, and some solid food. He has six wet diapers and one bowel movement daily. He has no history of serious illness, um,
Okay,
no medication.
look at the abdominal examination. Abdominal examination shows 2 centimeter protrusion from umbilicus that is easily reducible. There is no erythema, induration, and or tenderness to the bulbation. What is your diagnosis?
Hernia.
Yes, it's umbilical hernia. So in baby, umbilical hernia is like like it reassure that the mass will resolve, or we do not need to do anything
Until what year?
until 3 year. The spontaneous resolution by age 3 year but children with large defect or persistent defect are less likely to experience spontaneous closure, may undergo progressive enlargement of the defect over time. So umbilical hernia may be associated with hypothyroidism, Beckwith Wiedemann syndrome, trisomy 18, 21, and Ehlers-Danlos syndrome. A minority of the patient may require surgical intervention if intestinal incarceration develops or if defect persists beyond 4 years. So it should be resolution. It should have spontaneous resolution by the age 3 years. If it persists beyond 4 years, then we need surgical correction. This patient does not require any sort of intervention as there are no concerning findings. Okay,
Mhm, 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 mhm,
so
mhm.
we need to remember this.
Okay, next. A pediatric clinic implements a screening test for determining alcohol use in adolescent patients. Okay. The screening test has 85% sensitivity and 95% specificity. 15-year-old boy has a positive result prior to being examined by the physician. The prevalence of alcohol use in the adolescent patients in this clinic is 10%. Which of the following best explain how the positive result on the screening test affect the probability that this patient consumes alcohol? Oh, jeez, I forgot all
Okay,
my participants.
okay. This type of question, I am very bad at this.
I forgot. I was so good when we were doing biostats.
Okay,
I was like so good at
it is problem when you are dealing with bastard. That time we feel that we can do it, but if we in the exam I am very nervous while I am dealing with the bastard. Okay, okay. Likelihood ratio describes the probability of a given result in a patient with particular disease or condition under study divided by the probability of that result in patients without the disease. This can be conceptualized likelihood ratio true positive divided by false positive, or true positive divided by false positive. Likelihood ratio is related to similar measure of sensitivity and specificity. Sensitivity is the ability of the test to detect the test if it is present, sorry, detect the disease if it is present, and high sensitivity therefore useful in ruling out of the disease. Sensitivity can be calculated by equation true positive divided by true positive plus false negative, and specificity is the proportion of the people who do not have the disease and who test negative. High specificity is useful in ruling out of high specificity is useful in ruling out of the disease. Specificity uh, can be calculated. Okay, calculation. Mm, some statistical measures include positive predictive value, negative predictive value are impacted by disease prevalence. In this example, screening test for alcohol use has a high degree of sensitivity has high degree of sensitivity and specificity, which suggests that its proportion of true positive and true negative results is high in comparison to its proportion of the false and negative results. A test uh, with high ratio of true positive or false positive, true positive to false positive indicates substantial increase in the likelihood of the disease being present given the positive test result. Okay, make me understand.
No, I cannot make you understand this. I don't understand it. I can't. Yeah.
Oh,
I have
oh,
to go back to this. I cannot.
okay, if you got it, then make me understand. Okay, next.
Kid. 27 woman comes to the ED because of boils on her groin and in her armpits. She has had one previous episode during pregnancy 2 years ago requiring incision and drainage. Exam shows inflamed, tender, foul-smelling nodule in her left axilla with cerebrospinal drainage and red papules in the inguinal femoral region. A 2-week course of broad-spectrum antibiotic is started and the axillary abscess is drained. Which of the following is the most likely natural cause of this disease?
Okay, we need to diagnose first. What is your diagnosis? Then we need to remember the natural course of this disease. In the armpit, if there is something like boil or anything, it might be hidradenitis suppurativa. Like in hidradenitis suppurativa, there are some pictures in the world, like in
Mhm.
the armpit or in the groin, there is like boils and which is foul smelling. So it is um, it has a high recurrence rate. So temporary improvement with likelihood of recurrence. So hidradenitis suppurativa is temporary involvement. Temporary involvement of likelihood of the recurrence is common in diagnostic of hidradenitis suppurativa is characterized by development of double-headed comedones, inflammatory nodules, and sterile abscess in the skin and folds of the axilla, inflammatory regions, abdomen, groin, and buttock. Over time, chronic inflammation and disease activity may lead to sinus tract formation, hypertrophic scarring, and sites of involvement. Hidradenitis suppurativa occurs in Early adulthood. Risk factors include obesity, smoking, diagnosis based on clinical history, relapsing, recurring lesion, physical examination. Sinus severity is measured based on the formation of this sinus tract. Okay, the goal of the treatment is to prevent the development of new lesion and limit the associated scarring. Common strategies in the treatment hidradenitis suppurativa include smoking cessation, weight reduction, and decreasing friction in intertriginous sites. Topical antibiotics, clindamycin or oral antibiotic doxycycline may be sufficient for patients with mild disease, but severe disease TNF alpha inhibitor is needed. Okay.
Next. Okay. 62 female comes to the office. I'm having chest pain and my heart is racing. I can't catch a breath. I can't seem to catch my breath. 3-day history of worsening chest pain, palpitation, shortness of breath, reports non-productive cough and feeling warm attributed to an upper respiratory tract infections 5-7 days ago. Symptoms exacerbated by exertion and lying flat. Symptoms are alleviated by rest and sitting up. Has not had similar symptoms previously. 20-year history of hypertension and 2-year history of osteoporosis, mild anxiety, amlodipine medications, amlodipine, calcium supplement, and
Okay, come
vitamin.
to the physical examination because
Let me see. Physical exam.
yes.
Temperature fine, pulse high, respiration fine, BP fine, oxygen fine, BMI fine. Appearance awake and interactive. Pupils are equal, round, reactive to light. Conjunctiva is annective, whatever. Most mucous membrane is fine. Bilateral basilar crackles. approximately 1/4 of the way up the posterior lungs, and no bronchiolitis. Tachycardia with regular S1, S2, no murmurs, jugular venous pressure, I guess is normal. Abdomen fine, extremity fine, no neurologic exam. Neurologic exam is fine. ECG and parasternal left and four chamber echocardiography, whatever. Which of the following is the diagnosis?
Now look at the ECG. In the
Okay,
ECG, it is low voltage ECG.
okay.
Uh,
Oh, the
yes, and how we see the low voltage ECG? Like in the like in the left, there is bigger pillar.
in the
The
left. Okay.
yes,
Uh-huh.
this one. So it is it indicates that it is normal, like normally, and but the P wave QRS interval is very small, so it indicates it is low voltage ECG. There are
Okay.
some other criteria of the low voltage ECG, but in a visual uh, screening, you can find that it is low voltage ECG. And in the echo, I found that maybe calcification is present. L-
Mm-hmm.
So it
Because
looks,
it's white.
yes.
Okay.
So it looks like a pericardial effusion.
Okay.
So if you find a low voltage ECG along with some sort of calcification, so maybe mm, okay, wait. So this patient with chest pain, this patient with chest pain, that is worse and supine ECG with low voltage and echocardiography show hypoechoic fluid surrounding the hypoechoic fluid surrounding the heart has a presentation consistent with pericardial effusion secondary to pericarditis. Pericarditis usually presents with chest pain. Pleuritic chest pain often improves when bending forward. It can occur in patients with inflammatory, infectious, malignant condition such as viral infection. SLE lymphoma can present as complication of myocardial infarction. If not treated, pericarditis can lead to development of pericardial effusion, which, if large and quickly accumulating, can result in cardiac temperament. On examination, pericarditis show a diastolic frictional rub described as harsh sound. In diastole, pericarditis is diagnosed clinically and supported by inflammatory markers such as ESR, CRP, along with echocardiography, which often often shows pericardial fluid accumulation. Okay.
Can you read A and E?
Yes. Cardiac tamponade typically causes the equalization of the pressure among the four chambers, leading to impairment of diastolic filling, compression of the cardiac chambers, and obstructive shock. Uh, cardiac tamponade, uh, cardiac tamponade, cardiac tam, hmm, cardiac tamponade results from pericardial effusion that is either very large or has accumulated over a short period of time. Physical examination include back triad, cardiac temporal hypotension, distended jugular vein distance occur. This patient hemodynamic stability consistent, not consistent with cardiac temperament. Okay.
Okay. Next.
Yes.
Study conducted to evaluate the effectiveness of testing stool for occult blood. 1,000 men between the ages 45-60 who come to the physician for routine health maintenance exam are enrolled in the study. Results show that 70 to 100 patients with colon cancer have positive tests for test of the stool for occult blood, and 700 to 900 patients without colon cancer have a negative test for stool for occult blood. Which of the following is the most appropriate, most accurate conclusion regarding this study?
Okay, the prevalence as applied to biostatistics defines the number of the cases of a disease or condition as fraction of population is consideration at the point of in time. Prevalence therefore indicates the percentage of current cases of condition within the population under study. The prevalence of a disease may change over time or vary between the population. Mathematically, prevalence is calculated by dividing the number of the existing cases by the number of the population under the study at risk of the condition. In this condition, disease under study of colon cancer and the population in question in men is 45 and 60 years. Based on the data, prevalence is equals to 100 and the number of the men with colon cancer 100 divided by 1000 the number of the men in the study. The prevalence should be distinguished from this incidence. Incidence is the number of the new cases as the percentage of the total population at risk. So how they calculate,
The,
like 100 patient, uh, the most.
my thing is how do we know? I mean, we know. I mean, the explanation is clear. Prevalence is number of people that have the disease
This is
over
over
total
the
number of,
number of the population, yes.
and, and then incidence is new cases
Yes,
over population
population
over.
at risk.
But how do you know that in this question they are asking about the prevalence? I mean, like how from the
Yes,
question, how do you know
yes,
that?
that is the first question.
Like they just started explaining prevalence, but I'm like, okay, how from the question, how do you know that they were asking for prevalence?
I think that we need to do all the calculation like they have done in here. If we start doing the calculation like this, then one question is enough to end the exam.
Because even if you do the calculation like 100 over 1,000, okay, and then what? You get a number, and then what does that help you?
That is 10%. 100 divided by 1000 into 100%. Calculated.
Okay, so it's point one and then times 100. I'm guessing, yeah,
Yes,
10%.
yes, that they have done. But
Okay, so you're trying to say that you're trying to say that to calculate the negative, predicted, positive, sensitive, all of that,
yes,
and then see which one matches.
yes,
One, oh
yes,
Lord,
they have done it.
oh jeez, nah, this is
So
gonna take.
if we start doing it, then it is enough to end our exam
Oh jeez,
because it will take near about five
yeah,
minutes or more than five
yeah.
minutes.
Okay, this is not a question that can be on the exam because there is no way, there's no time to be doing all of this.
No, they in the exam like they actually try to trick you by giving this type of bigger questions because sometimes if it is the first question you will not want to leave this question so you start appealing to perform that question so your time will be killed. Maybe they are trick.
Yeah, because they calculated, and yeah, you see negative predictive is 96, so it doesn't match this one.
Yes, they
Positive,
have calculated all the things.
jeez.
Okay.
Okay, next. Jesus. Medical director of a multi-site This is a lot of biostats. Of a multi-site internal medicine practice wants to maximize the delivery of preventive services to patients. The practice has four sites, each employing one lead physician, one office manager, and 50 internists. Which of the following strategies is most likely to be effective?
So determination of a multidisciplinary determination of an action uh, plan on one multidisciplinary team representing all the site. So what does it mean? Like one multidisciplinary team that they will look everything like they will.
Mhm. Mhm.
Okay. Do you
Mhm.
need the explanation?
Yes, yes, please.
Okay. Mm, So quality improvement. So quality improvement is a framework that seeks to systematically improve and standardize the performance of medical practice. Quality improvement hinges on plan, do, study, act. Plan, do, study, act cycle, PDSA cycle. Okay. And and iterative process, an iterative process which providers plan and intervention, execute the intervention, study the intervention, and using quality measures identify success and areas of improvement for the next cycle. Quality measures that are timely and study and patient center are crucial. The medical director should first formulate the plan. Healthcare delivery is complex and the implementation of changes requires teamwork across the disciplines. As such, quality improvement efforts require collaboration from multiple disciplines, including physicians, nurses, social workers, administrators, and even statistician and epidemiologists. These very stakeholders would should be present at the initial planning meeting to build in and develop plan for increasing the preventive care that is feasible for all statisticians and epidemiologists. These very stakeholders should be present at the initial planning meeting by to build, buy-in, and develop a plan for increasing preventive care that is feasible for the discipline. Similarly, if a quality improvement effort will span multiple site representatives from each site should be involved in the planning meeting so that the needs of each site is addressed. Okay.
Did you read F?
Random chart auditoring by each office manager with results provided the respective lead physicians is likely to lead to change. If chart auditing happens without intervention plan, it is unlikely that preventive service provision will change, and quality improvement requires a plan or coordinated action. Okay.
Okay, next. Previously healthy 22 men comes to their physician because of a 1 week history of severe, frequent, non-productive cough. 1 week cough. Temperature is fine, pulse is high, respiration normal, blood pressure, I guess normal. Pulse oximetry on room 8 is 95, mild diffuse crackles are heard, reminder of the exam is fine. Check cells ratios diffuse bilateral interstitial infected. What is the diagnosis?
So diffuse bilateral interstitial infiltrate looks like mycoplasma pneumoniae. Patient's
Mhm.
fever is very low, like not high fever. High fever happens in like staph, strep. These causes actually high fever. And Legionella pneumophilia, like Legionnaires, there is a hyponatremia. Uh,
Okay.
Fever, pneumonia, there is a hyponatremia, and mycobacterium tuberculosis is more than 2 to 3 weeks of cough, fever, night sweat, weight loss, hemoptysis, not like this diffuse bilateral infiltrate. Okay,
Mm,
so
and
atypical pneumonia like chlamydia and mycoplasma can happen.
why
And
is it not Staph aureus?
Staph aureus, like Staph aureus, more commonly causes secondary pneumonia. Like patient has viral pneumonia, then the secondary cause of pneumonia is Staph aureus. Like patient has viral problem, viral influenza, then again he has high fever, cough. That would be the Staph aureus.
Okay. Next. 2-year-old boy brought to the physician by mom because of 1 week history of rectal tissue protruding from his anus when he strains vigorously during bowel movement. The tissue retracts spontaneously within 1 hour. Mom notes that his stools are hard. He has no history of illness and no medication. Immunizations are up to date. Growth developmental is appropriate. The patient paternal uncle has history of intermittent abdominal pain and diarrhea. He recently began a gluten-free diet on the advice of a friend. Who, the baby or the uncle? Oh, never mind. The patient's family dog recently was treated for worms. Examination of the patient shows no abnormality. The anus is normal. Which of the following is the cause of this patient's symptoms?
Okay, functional constipation is the most common cause of constipation in healthy children. Pediatric functional constipation after the introduction of the solid food to their diet, during toilet train, when beginning to school. Pathologic cause of pediatric constipation like congenital megacolon spina bifida, hypothyroidism, cystic fibrosis, diabetic insipidus, which should be excluded by a careful history and physical examination. Red flag sign constipation include constipation prior onset of the constipation prior to 1 month of the age, delayed passage of the meconium, failure to thrive, abdominal distension, intermittent diarrhea, or explosive stool or empty rectal wall, and midline hair pigmentary cases over the lumbar spine. Imaging and lab studies usually not most common treatment of constipation osmotic laxative or glycol based laxatives. Dietary modification should be done. Increase fluid intake and fiber. Manual disinfection or enema administration may be required in refractory cases. This patient likely has functional constipation as he does not have a previous medical history. Okay,
Okay, we are done. I will see you tomorrow
okay.
night.
We try to finish the like 50 question per day.
I mean, we did like actually, you will do like 20, but